I'd like to thank Dr. Streck and Dr. Castle for allowing me to present the best practice guideline for trauma center recognition of family violence. Many members of the APSA Trauma Committee, through their membership in Pediatric Trauma Society, have been working on putting together screening guidelines for child abuse, for specifically child physical abuse. Sentinel injuries are injuries that are highly associated with child abuse. We can all agree that these injuries should prompt an evaluation for child abuse. There are various examples that have been validated within the literature, including bruising and certain traumatic brain injuries. Why is this important? What we know is that sentinel injuries are the harbinger of what's to come for the child. And if this is not recognized and the child goes back to their abusive environment, they're at a higher risk for sustaining additional multiple injuries, each one escalating in severity and potentially leading to death. So why did APSA become interested in this? One of the things that we recognized is that there was no standardized way in how a child is screened in trauma centers. This led to the publication of the APSA position statement on screening for child abuse and the role of the pediatric surgeon. Importantly, it defined the spectrum of traumatic disease that these children experience and made recommendations. This work and other work by the Pediatric Trauma Society led Dr. Randy Bird to explore the idea of putting together a TQIP, American College of Surgeons Trauma Quality Improvement Program best practice for the evaluation of child abuse. A couple of tenets that were important to this guideline. We chose to offer as a best practice selective screening. There's two different ways to look at screening. First is a blanket catch-all screening program for every single child based on age, development, presentation to an ER, and all of them get evaluated for child abuse. And this has been done in countries such as Holland, and the Dutch experts have recommended caution in terms of resource utilization for implementing this type of program. So instead, we have recommended a selective screening so that certain key findings, what we call red flags, trigger a child abuse workup. Importantly, and what Hallie has pointed out, is that there are several screening tools, such as the 10-4 Faces P bruising tool, certain high-risk burn patterns, as well as 3 validated abusive head trauma screening tools that are indicative of abuse, but there are none for skeletal injuries. As a quick example, the Mary Bridge Children's Hospital screening tool was included as an appendix in the TQIP best practice guideline. Moving on to fractures, the TQIP best practice guideline did take a look at and summarize the best available evidence looking at skeletal injuries associated with child abuse in children. It does seem that the majority of literature describes children under the age of 4. So Hallie has made a meaningful contribution to the literature looking at adolescent screening patterns. In terms of younger children, skeletal fractures can be seen as sentinel injuries in certain pattern types, such as rib fractures under the age of 3, femur, tibia, and humerus fractures under the age of 18 months, fractures in unusual locations, Hallie described hand and feet, also there is scapula, etc. And it is important to consider metabolic disorders when you're working up a patient who's presenting with a fracture. If these fracture patterns are noted, it is important to start a child abuse workup. It also includes a series of laboratory screenings. However, I have to emphasize that child physical abuse can still occur in the presence of an underlying metabolic disorder, and the mere presence of a diagnosis such as hemophilia or metabolic bone disease does not exclude the diagnosis of child physical abuse. Skeletal surveys are recommended, as well as a 2-week follow-up skeletal survey. The list of the different views of the skeletal survey are included in the next 2 slides. with the second slide demonstrating a limited skeletal survey 2 weeks later. In conclusion, the American College of Surgeons Resources for Optimal Care of the Injured Patient mandates a process to generally assess, screen, treat, or refer a child suspected of maltreatment in all Level 1 and Level 2 pediatric trauma centers. Similarly, the ACS Optimal Resources for Children's Surgical Care advocates for a child abuse team to be available full-time for both Level 1s and Level 2s. All states, including the District of Columbia and U.S. territories, have laws about mandatory reporting for child abuse. We do recommend a selective screening process for child physical abuse in all trauma centers. It is important to note that there are still no overall tools that are validated for skeletal fractures as well. And trauma systems are poised to recognize child abuse injuries and provide a system of coordinated and standardized care for these most fragile of patients. Writing team. Thank you very much, and I'll be happy to entertain any questions.
Dr. Escobar, excellent talk. My question for you is, what do you see as the role of the pediatric surgeon in screening for child abuse?
Thank you, Chris. I really appreciate that question. I think that one of the reasons that APSA spent the time to create the position statement is that we believe that pediatric surgeons are perfectly poised to be the trauma team leader for the screening, evaluation, and management of these kids. We took the hypothesis or the theory that the level of injury that can occur in these children warrants the use of a trauma system. If we can standardize our approach to the screening and management of these children, we're going to see better outcomes. Based on that, we came up with a table that is published within that APSA position statement that highlights the different areas that we as APSA recommend in terms of screening for these kids. And the pediatric surgeon is the trauma team leader, but it is a multidisciplinary approach to how we manage these kids.